So these first couple of slides that we're going to go through are our mandatory disclosure requirements for CME and CNE. And without further ado, I'm going to turn this presentation over to Dr. Kelly. We're excited to have her back to facilitate today's session. If you are not familiar with Dr. Kelly, you can reference the first two recordings for her bio. So.
Welcome back, everybody. Happy Valentine's Day. Just to look at what we've done in the past and how it relates today, we talked a bit about data collection in session 2, and then about things you can do to improve antibiotic use through policies in session 3, and then practices and processes to improve stewardship in session 5. But today we're going to talk about pulling together that data into reports that you can share with each other and with your prescribers, and how to do that. So we have quite a lot of tools to show you today. So bear with us while we bring up the tools. Let's see, I need you to click so I can get the next slide in. Okay. All right, so we're going to talk about gathering and analyzing data on long-term trends in facility healthcare-associated infections and antibiotic use, using the appropriate denominators and comparison rates for your HAIs and antibiotic use, measuring and reporting adherence to the stewardship elements with appropriate benchmarks. I need you to click. Okay. So the requirements talk about the elements creating a system. So the elements are monitoring measures of antimicrobial use, monitoring outcomes of antibiotic use, and providing facility-specific reports. The CMS requirement is that you put these together into a system where you're monitoring, measuring, and then feeding back. So we're going to take you through some reports that you could generate that would make that happen. I need you to click again every time I can click. Yeah, okay. So the exciting thing about data is that it's no longer the case that people are alone in their own facility collecting data for themselves. More and more, we're actually collecting data for a huge national effort. And this started in inpatient care and is now moving into long-term care. So back in 2009, after some interesting testimony to Senator Henry Waxman, about how little we were doing to reduce HAIs in the United States, an action plan was created. The CDC started putting together the National Healthcare Safety Network, which is a huge computer system that many of you are using now. And in 2010, we started with 5-year goals for the reduction of healthcare-associated infections in acute care hospitals. This is a learning process. Every 5 years, the goals are redone. The definitions are changed continuously, and we get more accurate all the time and consistent and more fair. But it really starts with you looking at your data critically and making sure that they're accurate and collected consistently and correctly. So the National Action Plan, which is there on health.gov, started in acute care hospitals, moved into ambulatory surgical centers, dialysis facilities, talked about increasing influenza vaccination among healthcare personnel across the board. Phase 3, it moved into long-term care facilities, collecting data on things like C. diff. And then phase 4 is antibiotic stewardship. The first phase of data collection with antibiotic stewardship is how many of the elements is every facility covering. So as this rolls out, the infections prevention plan is continuously evaluated, and each state also collects data, presents data within their state. New Mexico has a committee that reviews these data and puts out a report every year, and also helps states gather data accurately and does validation of data through visiting facilities and seeing that they are actually collecting all of the HAIs and collecting the right denominators and applying the definitions correctly. The next slide. So this has been a colossal effort on everybody's part. Standardized definitions for HAI did exist, but they had to be updated and improved tremendously as they started to be applied across healthcare. And also healthcare has evolved considerably since these were first developed back in the 1990s, and especially in surgical areas. It took a lot of work to make sure everybody was talking about the same thing. Within acute care, we now have standardized infection ratios, which make everything a lot more fair. It really tells each hospital, how am I doing according to this baseline? And it makes it fair because it incorporates some hospital-specific factors like size and whether or not the hospital is a teaching hospital, which also implies some differences with the risks of the patients. We learned a lot about what risks for, say, surgical site infection should also be included when we collect data so that everybody is fairly measured. Electronic transfer of data is a big challenge. And then the collection of process data as well as outcomes can be done in the system. This took a huge amount of education and training, the development of a big computer system, how everybody got into that system securely has evolved over the years. And then to make it happen, CMS had to mandate it, and then we had to validate data during those state surveys. So as we monitor data continuously, definitions have been refined. For instance, candida in urine no longer qualifies as a urinary tract infection. We're seeing changes in how the labs report organisms such as coag-negative staph. Everybody had to be updated continuously on what might be considered a contaminant and so forth. So this is really a huge effort, but I think it's very exciting for people to know that they're part of something that's going on nationally and that there's a lot of support for what you do. So next slide. So here is the NHSN 2016 National Report for Acute Care Hospitals. Although these data are for 2016, the report comes out about 2 years later, or at least 18 months later, in 2018. So compared to the national baseline, which was remeasured or reset in 2015, they had a 7% drop in catheter-associated UTI events over 1 year, and an 8% drop in C. difficile events over 1 year. And so these are the kind of reports that we can see happening now across the country. So next slide. How about measuring processes? CDC is also reporting now on antimicrobial stewardship programs and how we're doing nationally. Next slide. And if you go to their website here, this is from 2016. I'm looking at some detailed data here on New Mexico, as well as you can see how everybody's doing across the country with the color chart. What is exciting is that only 2 years ago, these measures of how much stewardship was in place were only in about the 40%. So those were only 40-something% of acute care facilities met all 7 elements for antimicrobial stewardship, and now it's up about 20% in 2 years. So that's a huge progress. I just want you to see this also so that you're not too hard on yourselves and you realize even for acute care hospitals, getting all the elements in place has been a challenge, and it's not there everywhere. I mean, if you look at some of the states in the more northern upper Midwest, they still have probably largely less than half of the hospitals have all the elements in state in place. New Mexico, we're in the 56 to 63%. And the states that are very advanced, there's a couple of characteristics there. I can tell you Pennsylvania had some academic medical centers that were really in the vanguard of even the invention of stewardship. And then Chicago also, in Illinois, also had a lot of academic medical centers that really pushed stewardship. But even in places that mandated stewardship by law, such as California, you can see by no means do all the facilities have everything in place, at least as of 2016 when this was measured. So next slide. So what do we need to measure in long-term care facilities? There are three kinds of data. We can measure our processes, measure how much antibiotic we're using, and then some antibiotic outcome measures, which might be things like C. difficile, how much resistance we have in our organisms, and so forth. Next slide. So here's our first polling question. Our facility has adequate tools to gather and present aggregate data for long-term trending of antimicrobial use. Can we get reports from our pharmaceutical supplier, a pharmacy, our lab? Are we able to know how many antibiotic starts happened in our time frame? Do we know how many patient days we had per month? Are we collecting that data already for something else so we can use it? So I can see people here not that secure about having all the data that they need to get. So let's see. So what kind of data can we get? We'll talk about some different ways. So process data, we're looking for the completeness of prescribing documentation. As we discussed back in webinar 3, are people following the policy that we have, and that's there in a CMS requirement, for talking about the dose, route, duration, indication, rationale, that usually means treatment versus prophylaxis, and treatment site. Can we collect these data even with chart review? How can we put them together in a spreadsheet and make them add up nicely and look good for a report? The other kinds of process data are how are we doing on adherence to facility protocols or pathways, the antibiotic selection, what are we seeing? If we do a timeout 48 to 72 hours after the prescription is started, what's the result? If we see there's an issue with the antibiotic, are the recommendations of the pharmacist or the reviewing person who's looking at the culture, are they accepted by the prescribing clinician? Are any changes made? So I think next slide, we're going to be looking at our sheet. Okay, so we have a very nice spreadsheet that I want to show you. It's kind of big. We may have to scroll back and forth across it. And you don't have to collect all these data, but I just put in a lot of options there. Oh, we're going to blow it up and scroll around. Yeah, okay. So in your committee, decide, what are we going to focus on? Are we just going to look at, say, what people are getting for UTIs this month? Are we going to look at all antibiotics? A lot of this will depend on your volume of prescribing. You know, if you have a small facility, it's not unreasonable to look at all your antibiotics prescriptions for a month. Other facilities maybe just be more selective if there's an issue you want to look at. So these decisions can be made in committee based on any other data that you have around. Your total prescribing data, your infection control data may be helpful. And we have some drop downs here where you can put yes, no, did we, you can also update these. Yes, we performed a timeout. Was any change needed? No change was needed. Did we need to change it? What was the name of the new drug? Were there any adverse events? And Andy has put in some really nice summary data on these spreadsheets so that you can easily cut and paste these into our monthly or quarterly report, and even point out who's prescribing what. And one of the most interesting charts we always did was to look at what kind of change was needed and were the recommendations accepted. And there were some groups that did not accept the recommendations ever, and this is only through collecting data that you can ever really convince people to change what they're doing or realize that they're outliers. So it takes a while for these numbers to build up, but you might find, as we had at the VA, we had one clinician whose prescribing of Z-Pak was way out of line with everybody else's, and we were able to feed this back to her, and she was able to modify her practice. So physicians don't know if they're way out of line. They like to see what other people are doing. Is very helpful. So with the group, I just want to ask, what kind of uses do you see for this sheet? Do you think you would be able to look at this, look at your prescribing? Are there areas that you would like to do a systematic data collection on UTI or a specific drug? What kind of issues have you been seeing in your facilities? Any volunteers typing in? One thing I will say while people are typing in is, Excel is a really fun tool to use. You can sort your sheet and sort your columns by infection type, drug, provider, but always, always keep backups as you do your work, because sometimes you make a mistake. The other thing that I would counsel people to do is, in your committee, make an agreement about how you're going to work with spreadsheets. Sometimes I've worked with people who keep everything on their desktop computer and then nobody else has access to it. So that's fine when you're working on it, but you always want to put back a copy in the shared file on your server and label it very clearly as to what day it was worked on and by whom. So that's an important part of data management, is knowing who last worked on sheets and how you're sharing them and how secure they are, and observing HIPAA and all that other good stuff.
We do have a couple of comments.
Comments, yeah.
One says, great tool to track and determine our process if we are treating correctly and documenting correctly.
Okay, good.
And then another one says, our prescribers are rarely changing their orders. GSS has provided a tool that resembles yours, and it is effective.
Good. So how is the tool effective for you? Is it effective in creating graphs and presentations, or is it effective in giving data back to clinicians? Are people sharing these tools in their committee?
Yeah, it's going to take a minute.
Okay, some people are typing. I mean, there are some acute care hospitals that are lucky enough to have systems that actually collect this data for them, but it still actually takes a lot of human work to pull out what you want from those softwares like Sentry 7 and so forth.
So the data from the tool is shared in copy.
Okay.
And it is more effective because it requires me to assemble more information, and then I am able to present it clearly to our providers.
Right. So the tool basically creates a consistency and is really important to share with providers because, as I've said before, they tend to operate in this 4-hour window in the moment. And they really do appreciate, in fact, that somebody is collecting and accruing long-term data. So we'll go on to the next slide. Okay. So getting your data, if you are a little shaky on having consistent data reports, you can always do the point prevalence survey that we spoke about. And in fact, there were some questions about point prevalence survey. And so I developed a longer description. It's that Word document, I think. I think second row, third over. No, down one, down. Yeah. Yeah, no, that's the gap analysis. Okay, maybe scroll down. Maybe there's another row. Okay, okay. All right. So here's a point prevalence survey for antibiotic use. You don't have to do, this is so you can gather data on either a daily or monthly basis just to get you started on some data. So scroll down a little and we'll talk about the goals. So if you can't gather data in an ongoing way, you're going to have to gather some data maybe intermittently. So you want to gather enough so that you have a consistent metric to compare antibiotic use at different periods, and also find a reasonable numerator of cases to review and assess antibiotic use, and then capture all the details. So it's nice to have a numerator of at least 5 to 10 patients on antibiotics for your facility. For a small facility, that might be that might be a month's worth. Larger facilities, it might be a day or a week. And then use your denominator, it will be patient days. So if you are collecting data from one day, then your number of patient days is the census for that day. But if you use a longer time frame, like a week or a month, you're going to have to add up the census every day for that period, or have an average census if that's available to you. So select your dates, and then use your medication administration record, and then express your antibiotic use per patient days. So for a single day, you can talk about percents, because most people will understand that it's pretty clear. But for longer periods, once you start to have more than one day, to make it consistent, you need to talk about how many patients we have over the total number of patient days for the period. So for instance, if I looked at a week's worth of data, I had 9 patients on antimicrobials, and I had a daily patient census of 40 over a week's period. My 9 patients would represent 0.032 patients per patient day would be on antimicrobials. But what we usually do, so that we're not dealing with these decimal points, is we multiply everything by 1,000. So this gives us a number like 32 antibiotic starts per 1,000 patient days. Okay. So now I get a little wonkish here in that some facilities, mainly acute care, are doing a number called the antibiotic use ratio. So they are capturing not just the antibiotic starts, but how many total days of antibiotic treatment are going on in the facility. So that's a lot for most people to do unless you're able to collect that. So antibiotic starts is probably safer unless you want to do more counting. So here's a sample final report about how your point prevalence survey might look that you could bring to your committee. On date X, we had 10% of the patients on antimicrobials. 2 out of the 6 had inappropriate dosing based on their weight and creatinine clearance. The duration of antibiotics ranged from 1 to 3 weeks. 2 out of 6 had no rationale for antibiotic use in the chart, no indication. One patient was transferred to us from the local ED on an antibiotic with no stop date. Drug-bug mismatch was noted in one patient, and the antibiotic had to be changed on date, I should say Y. And then one patient developed a rash and Cephalexin on day 5. So you can see how even just collecting 6 patients, you have a wealth of information there to talk about. And you could pick any one of these issues to work on, like, well, let's look at our dosing of, say, Bactrim for these very small elderly people with impaired renal function. Maybe we can be using a single strength instead of a double strength, and that would be less toxic. Maybe we need to inform everybody that an indication and rationale for antibiotic use needs to be documented. Maybe we need to work with the local ED, have a call made when they get transferred to try and catch whoever did the prescription to see how long it should be. And then the drug-bug mismatch, that is a timeout that was performed. And then we also picked up an adverse event. So that's a wealth of information. So antibiotic starts can be one numerator. Days of therapy is a little bit more ambitious. So next slide. Okay. So this is the tool we just reviewed. Very important to be collecting some data now. Just do a quick data collection, because you will be surveyed sometime in the next year, I'm sure, and they'll be looking to see, are you reviewing your antibiotics, discussing the use, making a change. You don't need to do a whole lot of patients to find a lot of stuff going on. Next slide. So how about the data cycle? This is kind of like the PDSA, but I think about it mainly as the data. So data have to be changed into actionable information. So we collect our data and we have to review it and analyze it and accrue it and add it up and trend it. And then it yields some more information. We have to plan based on the data, and then we have to implement. So the plan and the implementation is where a lot of people fall down, you know, and then collecting again and seeing how we did. So there's a great deal of data collected in healthcare facilities. How much of it actually gets moved into change and implementation of change is questionable, I can tell you that. So don't get so hung up on the data part that you don't focus on the planning and action and change part. So next slide. So here's another question. Our antimicrobial stewardship and infection control group establishes priorities for action on a regular basis. Are we talking about making changes based on data, instead of just looking at data? Yeah. So, yeah, just there's a lot of tendency just to look at data and say, keep monitoring. So if you find yourself saying, keep monitoring, the question comes up, should you still be monitoring that indicator, or is there something else you could be looking at that would yield a bit more fodder for changes and improving patient care? So once a benchmark starts to reach 95% consistently, then you can kind of drop it. It might be okay to come back in a little while to make sure that people aren't falling off the wagon with whatever you're monitoring. But don't just keep looking at your data meeting after meeting without thinking about doing something. Maybe often the tendency to do that happens when you have small numbers, and everybody can always dismiss oh, we just had one UTI, you know, or we just had one C. diff. Okay, what do we do about it? We don't know, right? That's why when I was at UNM and VA, I created these reports called megatrends, and they showed the year-to-year data. And so instead of onesie, twosie, you started to see 20, 30 of something. That was a lot more meat for people to get their teeth into and think about how we could start to improve from 20, 30 of something as opposed to just onesie, twosie. So this is why collecting the data, aggregating it, rolling it up is important. So next slide. So what kind of actions or interventions have been suggested by your data reviews so far? What issues are people seeing? What changes need to be made? Okay. Daylene, did you have something? Is she on the phone or typing? Okay, maybe. All right. Well, we'll see if anybody will contribute a little bit later. Oh, okay. Here we are.
We identified hand washing as an issue in one case.
Okay, hand washing, right. So then if hand washing was identified as an issue, then what was the intervention that you took with hand washing? Any response?
I think we have a delay.
Okay, we have a delay. So we'll break in with that later.
The intervention was to audit staff for hand washing and educate at the time of audit.
Okay, so education at the point of audit, okay, i.e. direct intervention when the hand washing was not occurring, I assume. Okay, yeah. So the thing to do is, you know, you corrected that at the time, people remember for a while, but you have to audit again later because they will slack off. It's an ongoing issue, always. So, next slide. So here's a roll-up tool that I modified a little from the AHRQ tool because they didn't really have any numbers in place to show you how this would work. So this is going to summarize your data monthly. You're going to have to determine how you collect your denominators on the patient days. You're going to have to determine, are you just collecting antibiotic starts or total antibiotic days? It will summarize your numbers monthly, but always be prepared to drill down because people will have questions like, what happened in February? And you could say, well, we had an outbreak of something and 6 people were treated for whatever. So let's look at how this might play out with the numbers. So these formulae are implanted in the Excel spreadsheet. So in January, we had 500 resident days, okay? So that means our census every day added up to 500 for the month. We had 4 antibiotic starts. And then if you click on that 8, Andy, okay. So, okay, look at the formula up in the formula bar. You put in C8 over, where is that? C8 over B8 times 1,000, and I get 8. So this is 8 antibiotic starts per 1,000 resident days, okay? If I was very advanced and able to collect how many actual antibiotic days or days of therapy I had from tool 2, I could put that in, and then I could calculate the number of antibiotic days over patient days. I could insert that column, and then I could also put in our number of antibiotic starts meeting the minimum criteria, say for whatever infection, UTI. So of the 4 antibiotic starts, 3 met the minimum criteria. We had 75% meeting the minimum criteria. So this is now nice. The numbers are still small, but over time, you'll start to see some trends. Generally, trends aren't statistically significant until you get about 35 in your numerator. So you can see if you roll this up by quarter, you might be close, or by 6-month period, and you could start to feel that you were making some changes. But small numbers like this are unstable, so don't get discouraged if they fluctuate somewhat. So next slide. Okay. So we could talk about how many new starts are initiated per 1,000 resident days, which is the number of new antibiotic prescriptions per total number of resident days. We could talk about how many antibiotics are just for urinary tract infection over the resident days, and just focus on one condition, for instance. Next slide. And then if you're really wonkish, you can do more things with your numbers. Each day that a resident receives a single antibiotic is a day of therapy. If they're getting 2 antibiotics concurrently, it's 2 days of therapy. Okay, not everybody can count that kind of thing. The antibiotic days of therapy would be the sum of all antibiotic days for residents in the facility during the given time frame, and then our antibiotic utilization ratio would be the total monthly days on therapy over the total monthly resident days, and you can also multiply that by 1,000 to make your number a little better, easier to work with if you have too many decimal points. So everybody wants to know, are our numbers good or bad? Are we good or bad? So this was something that we dealt with early on in the days of the NHSN. How are we doing? Can we compare ourselves to other people? So the problem is that even in New Mexico right now, for acute care facilities, many of the numbers are so small, say for HAI in the acute care facilities, that they cannot have their own statistic done for them, and we can only do it for the state as a whole. So how are our HAI data currently? We'll go to this article in a second because we can bring it up through the link. But I just want to focus on the measurement of processes. So people throw around the term benchmark kind of loosely. You can't actually benchmark an outcome. You can only benchmark a process. But remember, the process, you are controlling it. The process has multiple elements, and you can set a goal for that process of, we're going to meet this process 90% of the time, we're going to meet it 95% of the time, and you can actually reach statistical significance because you're measuring that process all the time. Like we talked about hand hygiene. You can sit there for 5 minutes and see 35 opportunities for hand hygiene happening and not happening. So you can very quickly calculate how you're doing in that process with a lot of numbers that are very significant. So let's just show you what is currently available for HAI comparison data. For those of you who kind of want to know what's out there right now for your county and your C. diff data in terms of outcomes. So this is open access because it's data collected by CDC, and we're going to scroll down to, if you click on the side there, Sandy, on the left, it says infection rates, and it should jump to it, right? Yeah. I think it was up in the top row, top way up. I think it was the first thing, yeah. Okay.
Okay, there we go.
So maybe you can click, see down on infection rates, just jump right to that. And then we can blow it up and see if we can get to the tables, because there are some tables in there. You can probably just flip, I would flip the, you see where you can go up and down on the pages, those up and down arrows to your left? Yeah, okay. All right. Okay. So they just, okay, so here's, it's a smallish sample of facilities across the country. I think it's just a few hundred who were in the vanguard of reporting data. And I see we have some from New Mexico. This is very good. And they're reporting data into the NHSN, long-term care facility data reporting component. So let's just scroll down and see some results tables here. Infection rates, that's the characteristics of the facilities. Keep going. They actually collected, okay, so there's crude facility infection rate. So let's just look at that for a second and blow it up a little. Okay. Sometimes you can go zoom to the top. You see next to the hand, to the right of the hand, that's a zoom, I think. We can go to like, yeah, okay. So here's C. difficile. They have 146 nursing homes reporting on C. difficile. They have 667 cases. They had a total of 6,800,000 resident days. And scroll over, the overall rate was 0.98 cases of C. difficile, and this will be in per 1,000 resident days. And there's the percentiles, okay? So you can see the bulk of the cases were occurring at the rate of 0.7 to 5.62. So that's a huge range. So the median, a lot of them were reporting 0, okay? So the median is the 50th percentile. So half of the facilities are below that and half are above. So half of the facilities are really reporting 0. And then the others are reporting up to 5. So that's a big range of rates. You also have a number of facilities. I think the next one is UTI, urinary tract infections. All of them, they break it out into catheter-associated and non-catheter symptomatic. You can see a lot of the facilities are not reporting any. And then the 50th percentile is, they have a rate of 0.29. And then the 90th percentile have a rate of 1.15. So big range of rates. So let's go to the next slide. And I'm just going to talk about how we can use some of these very preliminary data. So next slide. So these are the kind of data that we used to have in acute care before we had SIRS, which are a little bit more statistically valid and easy to use. So we would look at these published rates. If you're up there in the 90th percentile rate against this sample group, you should probably look at what's going on. You probably have an issue, okay? You may have an issue with how you're applying the definition, okay? Or you may have a real issue with, say, C. diff or catheter-associated UTIs. If you're reporting 0 and in the bottom 10%, be a little skeptical about that. Make sure that you are collecting all the cases and that you're using the right definitions, and that it may be that you are, but just be aware that often not finding any cases means you're not looking for them, or for whatever glitchy reason, you're not getting the lab report. And this is seen a lot when we try to validate data. Sometimes lab reports on weekends or at midnight kind of don't come through, and just be aware that sometimes you have to run reports monthly to make sure that you didn't miss any because of how computer systems update and so forth. So we don't really have SIRS for long-term care facilities. They're going to have to collect and analyze a lot of data to know how much does facility size, complexity, and patient population play into the rates, so that we really know what is an expected rate for your kind of facility. So this is very preliminary comparisons that can be done. Next slide. So how about feeding back data to your prescribers? So that chart I just showed you may be helpful for you to discuss against your rates that you calculate for your C. diff and your county in committee, and determine if you're in the 90th percentile, what's going on with that. Okay, so that's just an FYI. So the next part, as we saw with the CMS requirements, there's got to be some feedback. So this is an AHRQ tool, letter to physician. This is your monthly prescribing profile. And there's different ways you can present this. You can cut and paste from a sorted spreadsheet to let them know what they prescribed and what the outcomes were. If they are outliers, you may be able to let them know in some anonymous fashion, like, this is how many prescriptions are being written by provider X per patients that provider X is covering, and one person is off the chart. It's a little hard to do this in long-term care because you don't really know how many patients each prescriber might be responsible for. So that's a lot of data collection. But if you can just have people compare themselves to the mean overall, that might be helpful. So if there's knowledge gaps, people are using antibiotics to which things are consistently resistant and maybe need to change what they prescribe as first-line therapy. You can provide an antibiogram as well as this, or include guidelines that have been developed. So some kind of feedback is important. Next slide. So here's another polling question. Is anybody out there doing an annual report on antibiotic use that is communicated to facility staff and prescribers? Just wondering. Strongly disagree? Yeah, okay. So this is where you will get to eventually when you've been collecting your data all along. It's a very, very powerful tool. So next slide. So this is a great thing to show any surveyor. So what you want to do, use your minutes and materials from your Infection Control Antimicrobial Stewardship Committee. Summarize your infection control data for the year, your overall HAI rate, C. difficile, counties. Compile your available antimicrobial data from the sheets. How many starts you had per month. You'll have to use resident days as your denominator for the year. You may be able to figure that out from an average census. You want to summarize your process data. And maybe there's been some changes along the way that you could point out. Like in the first quarter, we had only 20% adherence with the prescribing documentation requirement. And then by the fourth quarter, we had 70% adherence. That's very powerful. It doesn't sound like much, but just showing that you actually measured and intervened is very powerful. So you'll want to include in your annual report the guidelines that you developed, your most recent antibiogram, flu shot reports on patients and staff, any changes to the formulary that you made, total antibiotic use, if you can get that from your pharmacy, broken out by drug. That is really nice to compare year to year as you start to build your data, and any quality improvement projects that impinge on infection control, antimicrobial stewardship, like what you just did with the hand hygiene. So this is a great thing to put together, share, and then state your goals for the next year and share it with the facility. So this is starting to develop that longer time frame. I mean, you can see that NHSN has taken 10 years to get where we are today, which what you'll see often is a dramatic improvement initially, and then the later improvements are kind of more hard fought detail work. But you can make a lot of headway in the first few years, and starting to build your annual reports are really the documentation of the work that you've been doing. So next slide. Okay. All right. So here's another chart that is a great way of looking at everything from a patient's perspective. So we used to use this a lot, say, people would get very excited with, oh, we're doing so well in our skip measures. We have over 90% adherence to the correct dose, timing, and discontinuation of antibiotics for the patient undergoing surgery. But then when you looked at each individual patient, their experience was not 90%. So if you look here at adherence to prescribing over time, this would represent a number of patients. You might find that when you summarized your data, that you have 30% of the patients have their indication and rationale noted. You have your dose noted 85% of the time, your duration 80% of the time, your route 95% of the time, meeting minimum criteria 60% of the time. That all doesn't look so bad. Now these are numbers I made up, so let's change that 30 to 6 to say 70, okay? All right, there you go, okay? So you think, oh, we're doing, 70 to 95% is okay. But when you look at it from the patient's perspective, only 50% of your patients are getting everything done correctly. Okay, that's the different way of collecting the data. So when you present it like that, it's like, wow, if I went into this hospital or this nursing facility, what are my chances as a patient of getting everything done correctly with the antibiotic prescribing? Only 50%. So this is kind of an eye-opener that pushes people past that complacency when they see, oh, people tend to focus on, oh, 95% we're doing really great. For instance, in community-acquired pneumonia, it was like, yeah, we're doing 100% on measuring the O2 sat. Yes, well, okay. There are things to do. They're a little harder than measuring and recording the O2 sat. So this is kind of the reality check from the patient's viewpoint, and it's a good way to present your data if you feel that people are getting a little complacent about how they're doing those stuff. The next slide. So any more comments or questions about all this wonkish, chartish kind of stuff? Once you get into Excel, I don't know if we have any Excel whizzes out there, it's really kind of addictive and a fun tool. So you can present your data a lot of different ways. Andy made some nice sample charts. How do people feel about their ability to collect and present data? Does everybody have Excel?
I have one comment. Love Excel.
Love Excel.
Love Excel.
Okay, all right.
Another comment. Yes, we have Excel.
Yeah. So showing some trend lines over time, especially the mega trends, people find that data quite interesting. But one more tip about Excel, don't overcomplicate your charts and don't use some of the stuff like the 3D bars and stuff like that, because those actually obscure the data. So don't, they have a lot of stuff in there that's kind of, I don't know, business presentation oriented, and it's a little distracting. So keep it simple, blow up all your data labels big so that people can see what the charts are. I hope people can get some use out of these tools, because all the hospitals where I've been, the antimicrobial pharmacists really, if you did not have a software to do it for you, they were all using basically the Excel spreadsheet. Any other comments or questions?
No other comments or questions at this point in time.
Okay, we'll just move on to the last thing here. So next session, we're going to be talking a bit more about the microbiology lab and our relationship with the lab, and also communicating between facilities, acute care, long-term care, and so on. If anybody is able to share any antibiograms from your facility, I'm really interested in seeing them, so we can talk a little bit about what they show. This can all be done anonymously. I don't know how many people have access to antibiograms, and we're going to try and get some more antibiogram data going, and talk a bit about some basic microbiology, which is a big part of infection control, and I think it's one of the things that people find the hardest when they're working on infection control, is the bugs and how to make sense of them. So I think with that, we are almost at 3. So thanks for tuning in, everybody.